Thank you all for being so patient listeners and your attentiveness. Now we are having the last technical session of the day before we have a query session. So we already have the speaker on the stage. So Dr. Kumar M. Dhawale, who is a psychiatrist by training and a homeopath by choice. So, sir, you will be talking on integrated approach for management in IPD of homeopathic hospitals. So over to you, sir. Green one.
Good evening. It's a great pleasure to be here and a privilege to be invited by the NCH to deliver a part of our experience that we have been having at our center. Government of India as well as Ministry of Ayush has been trying to foster integrated medical care in our IPD. And I think that as what was said in the morning, that India remains the home for homeopathy now, with the homes in the USA and the homes in UK getting eclipsed. The stakeholders for integrated homeopathic care are very many, right from patients to students to teachers to academicians, researchers, government, insurance companies. You have, say them and you have them. So what we are trying to cover during this brief half an hour is have a brief idea about what type of clinical conditions integrated care can cover. More importantly, how we can make this possible. And since we are addressing medical superintendents and medical officers, what would be their role in it, and what mileage that homeopathy and homeopaths can secure through this. Most of the experiences are based in our Palghar hospital. It has been a hospital since 25 years now. We are celebrating the Silver Jubilee. And we have built up this hospital through donor contributions. And we have an opportunity to practice homeopathy in the ICU, NICU, and the dialysis center. So some of the cases that I would be talking about would be from these places. The first case is right from the beginning, almost at the time that we started the hospital in 2006, when newly admitted residents were watching a delivery which they had never seen. And this was a primie who had come, and she was having a partially dilated. Gynecologist was in the picture. He examined. He said this patient will require induction. But he said, let homeopathy take over and see what they can do. Totality was picked up by the residents. The medical officer helped them to come to the conclusion, did the repertorization. Kalikab was the remedy administered, and to their amazement, they found that a single dose of Kalikab led to the birth of a full-term normal delivery. This was their response. We were happy because it was our first experience of delivery of baby with homeopathic medicines. But what is the learning for us in this setting? The learning is that we have to train for quick and sensitive history taking, good powers of observation, good ability to synthesize the symptomatology, good idea of posology, good idea of remedy reaction, and ability to integrate all this in the totality. And it always helped to keep the obstetrician on our side, because obstetrics is a tricky branch. And unless we are having people with us, it becomes difficult. We have been shown pictures. Dr. Subhash has shown a picture of ulcer. Let us see how the whole thing is managed. So this was a 55-year-old laborer who came, extremely offensive discharges, very, very deep ulcer, necrosed, anemia, diabetes. The surgeon was on the scene. Surgeon said debridement is necessary, followed by skin graft if the wound heals. If it does not, then amputation. So we have to see at what point of time the patient is coming. Surgical management is instituted. Everything that is required by the surgeon is done. He has come to the end of his road, and he says, now we might have to amputate. So he sends to the homeopathy, see what you can do. This is the state of the foot. Again, we go back to trying to erect the totality. Detailed case taking, detailed repertorization, come to Cilicia. And just as what Dr. Farooq Master told us, that don't go to the chronic remedy when the acute remedy is staring you at your face. This relationship of remedies, go to hip herself. And you are able to see single remedy administered over a period of time, 10 days after the treatment is instituted, 3 weeks, 4 weeks. I think what is most important is that there has to be a mutual respect between the two disciplines. If surgeons don't respect homeopaths and homeopaths don't respect surgeons, then this sort of a thing is not possible. So one knows where one places our foot and where one withdraws. And a knowledgeable homeopath, a teacher, and I think that this is very important. We run colleges, but the college teachers must enter into the homeopathic IPD and OPD so that their knowledge can be shared and can be practiced. And I think in all this, the role of the medical officer becomes important because it is the medical officer who is conducting the orchestra and who tries to bring all these different forces together at different times. We have seen chronic surgery. Now let us try to look at acute surgery. It's important because we think that homeopathy is an adjuvant. But homeopathy can be a remedy which can do the job. And this is what this case will show you. This is a young fellow who has come, and it is clear that he is going in for an acute abdominal state. There is an appendicular lump which is seen in the USG. You can see fluid levels. So we are looking at a state of obstruction. Intestinal obstruction secondary to acute appendicitis. Again, the surgeon is on the job. He is doing his work. All has been done. No change. So now he is saying that morning we will operate. So we have the idea to ask him, can we do something? Patient agrees, surgeon agrees. Observation. Calm, doesn't complain anything about his illness, even though he is severely ill. Follow the bogus approach. Take care of the susceptibility. Opium 200. Look at the manner in which opium responds, or the patient responds to opium. You have, for 4 days, there has been surgical treatment going on. And within a few doses of opium, you are having bowels opening up. The stomach is clearing up. Normal bowel sounds. Discharged without any operation. So we are able to see homeopathy in emergencies, in hastening recovery, in avoiding surgery. All the advantages of homeopathy we are able to see. But what does it require is there on the right side. Scientific practice of homeopathy will require a proper assessment of pathology and possibilities, quick case taking, interpretation and totality, assessment of susceptibility and pathology, accurate and standard systems for follow-up and investigations. This is another case in the ICU, where we can afford palliative care. A super senior citizen is admitted in a wheelchair, brought from a geriatric center in the locality. And she is coming with fever, very high fever, and lung infection. Able to see the investigations, shows that there is definitely a medical renal disease, a chronic kidney disease, minimal ascites, and a lung infection. In the ICU, she is admitted. Physician has done all what he would normally do for a patient with CKD, accelerated hypertension, and acute kidney injury. Nephrologist we have, he comes on the scene. He prescribes Lasix every 1 hour. And he says that if this is not responding, then we might have to go for temporary catheterization and emergency dialysis. Patient's condition after 3 days in the ICU: irrelevant talking, irritability, there is electrolyte imbalance, blood pressure is high. Series of consultations from the medical, the surgical, the nephrologist. And all of them are looking at taking the patient on to dialysis. Family is not willing. Family doesn't want to subject the senior citizen to any more trouble. They are willing for homeopathic medication. The medical consultant wants to go on to higher antibiotics. And obviously we reason saying that higher antibiotics are going to cause further higher deficit in the kidney. So we have to persuade the medical consultant to hold on. We start with uranium nitricum based on the totality. And you see the manner in which the patient responds. Within 3 or 4 days, the patient is much, much better. And the patient who came in a wheelchair is going around in an ambulatory way back to the geriatric center. This was long after her discharge. We got her investigations done, and she's quite stable and doing quite well. I think this is where we are looking at the role of homeopathy in the future. Because as we know that we are steadily becoming an older citizen nation, multimorbidities are on the rise. And therefore, our intervention as homeopaths at the right time, taking careful note of the susceptibility, is going to make a huge difference in the way in which we'll be managing this lot of patients. So, giving maximum comfort with dignity. I think that should be our mantra as far as this age age period is concerned. We have prevented a patient from dialysis. Now we are looking into a patient on dialysis and what homeopaths can do in order to try to get the patient off dialysis. So this is a patient who has come to us, 55-year-old, referred from a dialysis center to a dialysis center because our dialysis center is closer to them. And you see that he has got bilateral renal calculi, hydronephrosis, and has been extensively investigated. You see the brief way in which the illness has developed, from hypertension to the stones, to the uremic symptoms, and finally to acute kidney injury, with the creatinine shooting up to 29.2, which led him to the dialysis center and extensive investigations. What is very relevant and what again Dr. Master mentioned is the mental state. Totally depressed, feeling hopeless, doesn't want to get into any further investigations and just wants to now wait for the end of his life. He has become dependent on his brother and he doesn't find that at all comfortable. This is the process that he has gone through, right from the urologist advice, who says that now the only thing that can be helping is retrograde intrarenal surgery, which is again a high-risk procedure, which the patient might not be able to sustain. So the patient has come back to us from the tertiary center. So now we are back to hemodialysis and back to our homeopathic unit, which is looking into the dialysis. So this is what we do: detailed case taking, Lycopodium 0/1 on a daily basis. And you see the remarkable way in which the patient responds. Within 2 weeks, the urine output increases, the appetite increases. A month later, his mood improves. He's cracking jokes in the dialysis unit. Within 6 weeks, he becomes ready for the renogram. And after 2 months, the nephrologist says that now since he is so much better, let us try to keep the HD on off control. And let's see how he does. And here we have a renogram which shows that one kidney is functioning well, almost to the extent of 89%. And the stones have disappeared under Lycopodium. So we are able to see that this patient no longer goes back to the hemodialysis unit. The patient remains outside and ready, well, and back to work. Now this case is a particularly important case for us because the medical officer who was in charge of the dialysis unit, who became consequently a medical lecturer in our medicine department, was a sincere and a passionate person who was actually living in the hemodialysis unit and caring for patients with a rare heart. And with so much of her heart and her brain involved, I don't think that we should be surprised that we can get such good responses. So it is necessary again here to emphasize the role of the medical officer. Because whoever is a medical officer is the person in charge, is in close liaison with a number of people, including the patient, the consultant, the tertiary clinical centers, who networks with a lot of other institutions and who is able to deliver the final result. This is a story, second last story, of a patient, of a child who comes to us in an extremely difficult state. You can see he's a 5.5-year-old, repeated fevers, repeated suppression, repeated skin eruption which has been suppressed. So I think all us as homeopaths who are aware of certain susceptibilities would be able to understand what this is likely to turn into. Here we have, he is coming to us with convulsions. And slowly he responds into a comatose state. This is the examination in the emergency unit when he is admitted into the ICU. Now the problem in this case is that the Glasgow Coma scale is just 3, which means that there is not very good chance of him ever recovering. Viral encephalitis with grade 3 coma, getting constant convulsions, status epilepticus. Pediatrician is saying, don't treat him here. He's not fit for treatment. Please send him to a higher center. The father says that I have not seen Mumbai. They are from the tribal area. So they will say that, no, you do whatever you want to, let the child die also, but let the child die under your care. Pediatrician finally is persuaded to give a high risk. Convulsions are still continuing. The pediatrician now says, send the patient home. Because it is very important for us to realize that consultants in this situation do not want to be shouldered with the responsibility of a patient dying on their hands. They would like the patient to get away from the hospital and from their name. So that is where, as I said, the medical officer comes into the question. And here our medical officer was extremely passionate and extremely determined. Again, we resorted to Boger's totality. Belladonna, 10 m, every 10 minutes. Subjective and objective symptoms were raised. वो दिखा सकते हैं? I'll just try to show you very briefly. Okay. This was the picture when we started Belladonna. Yeah. दिखाइए. सब एक एक 5-5 सेकंड के लिए दिखाइए.
त्यांना कपटी पाडून घ्यायला आता करता येते इकडे त्याचे पाहून टाकी ते तसं पाहून टाकी ते तसं तुला आले आता करते तुला आले करते तुला
पाणी सागर हाँ लाइट देख रहे हैं. कल थोड़ा फोटो को भी अभी लग लक्षू. हाँ हे कोण आहे? बाबा आहे. अरे हळू चाल बापरे हळू चाल तू.
हॅलो आसा आसा
Yeah.
थांब.
I think we have to thank our patients also sometimes, because patients allow us an opportunity to try our medicines. If the father would not have permitted us to try, we would not have got this experience. We would not have understood what belladonna can do, and we would not have got a name for ourselves as an institution which can perform miracles. But I think in all this, what Dr. Naveen mentioned was the heart. It is the people who are going to be responsible for whatever good we do and whatever good that we can do. The last aspect was the research and how IPD can be used for research as well. So we have been working on diabetes mellitus for a long time. Since 2002, we have done an extramural research project on diabetes in the community. And we have had a number of good experiences in the OPD. In the IPD, we wanted to find out how we can help in the diabetes. And a single case of ketoacidosis was treated with homeopathy. And we found a good response. Now, when we are treating ketoacidosis, obviously, we cannot treat ketoacidosis on our own. We will deal as an adjuvant, homeopathy as an adjuvant. So we wanted to know whether homeopathy can be used or can be proved as a research, through research, for its role. So we planned a research where we said that whatever standard treatment of diabetic ketoacidosis, which is on the left side, and when we are looking at the homeopathic intervention, we will try to look at how we can correct the susceptibility and how looking at a remedy response and the remedy totality would help. So accordingly, a quasi-experimental approach was followed, and we had a proper research protocol which was designed, which met with the approval from the medical consultant. This was the methodology that we adopted. Again, we had to have a proper observation parameters, which we also did. These were the cases. These were the type of presenting complaints that we had in the cases. Look at the results. Post 24 hours, you see the homeopathy. You are able to see that the symptom score, when homeopathy is combined, reaches much better, as well as the blood glucose level reaches lower. So we are able to have a hospital stay which reduces when we are putting the patient on homeopathy, as well as standard treatment. These were the type of homeopathic remedies that were used in this research project, and the principles of the homeopathic treatment that we followed. This was presented last year in World Homeopathy Day by our research team. So when we look into the research aspects of integrated health care, then I think it is a little difficult aspect, because we need to have everybody on board. A final protocol has to be jointly brought about, and a lot of things come up while we are exercising the methodology. So, but research is possible, and it will garner a lot of advantage if we are able to institute it. So integrated approach to patient care it needs a teamwork. It involves working with doctors from other systems, respect the scopes and limitations, and with mutual respect. The resultants, as you see and as you have seen, are extremely heartwarming. And I think that as we have seen, that integrated homeopathic care is something that we need to really institute with a purpose in our institutions. It is something that will take us a long way. And what we have been talking about, that it can be cost effective, and if we want to convert our centers into profit centers, then integrated homeopathic care is one of the effective ways of doing it. I think this is what Dr. Dhawale said, and this is what we are trying to follow in our practice, that we have to follow it as a mission, then only we are able to give the type of results that we have seen. This type of work is not possible without our team, consultants, medical officers, allopathic consultants, as well as number of donors who have given a lot to support our efforts. Thank you.